And so without further ado, let's introduce Dr. S.
Dr. Schmahmann, you're up.
Hi, everybody.
Everybody can see him okay?
Good to see you all. And good to see you all at home and here and hanging in there. I was listening to the conversation. It sounds like everybody's finding a way to get through this. So nice to see you all. And this is the way of the future. So we'll be seeing you occasionally, I think, but a lot of it's going to be this way, at least for the next little while. This is a different time for all of us. You know, it's there's a lot of soul searching that goes on, a lot of thinking about what this means for us, what this means for our society, for the way that we engage with each other, for the way that we stay in touch with each other. And I've been listening to a lot of things that, you know, for us have to do with the Passover Seder coming up. I know that Easter's coming up and people are trying to figure out how to go about celebrating these major milestones in their own faith and do it away from everybody else and in isolation like this. And I think there are lots of lessons that we can try and draw from this. That given this reality of what we have, how do we get through? So I think, and what are the lessons we can draw now about how we handle this? How best can we handle it? How can we stay nimble in trying to respond to all of this? How do we get through it? And then in thinking in the big picture, where do we go from here? What does this leave us with later on? What are the lessons or the experiences that we're having now that may have long-term consequences for how we think about ourselves, our place in our families, our place in society, how we think about our relationships with each other, how we relate to technology, how this may change things for us. So we're in the COVID era, and there will be a post-COVID era. And I think that, like everybody else who's come to the same conclusion, a lot of things are going to be changing, and let's hope that we can find a way that they'll be changing for the better. Right now, this is a scary time. This is a nasty bug. And although not everybody who gets it gets terribly ill, there are people who are just not doing well at all when they get this infection. So I can go through some of the big picture things in terms of the virus itself. I can tell you about the hospital, tell you about how we are responding to it, and then how this ties into you. What I can tell you right now is I'm actually in conversation with my colleagues around the world who are the ataxia specialists in their own countries, and we're about to put together a little piece to help our colleagues in cerebellar ataxia and neurology deal with the issues that are coming out of their patient populations that we all work with around the world. And so your own input will be very valuable as we knock our ideas into shape. This started happening yesterday, and we'll get this done within the next day or two. One thing that we've learned about it, even in the publication sphere, is that the papers are getting published online almost immediately, which is a big difference from months of delay in getting an academic public paper published for people around the academic community to read and to learn how to handle their patients. From the perspective of Mass General, which is what I know, we're hearing from our hospital daily, usually twice a day, from the clinical side, from the research side, from the Partners Healthcare, from the medical school. So we're getting emails twice daily. There are Zoom conversations that are taking place across the clinical sphere, across the research environment on a weekly basis, and hundreds of people log in to hear the updates from the hospital. It's a very impressive effort that they're making. And I think that we're actually very fortunate in an environment like MGH and the Brigham and Partners Healthcare, certainly I can speak for MGH, are pulling together to make sure that they are doing everything they can to avoid the kind of medical care scenarios that have been happening in other places around the country. They've now been able to secure the personal protective equipment that is critical for the frontline people to wear to be able to take care of patients who are ill. The hospital has geared up remarkably. They have a number of different sites around the hospital now to see people who think they may be affected. The ICUs are now expanded into other areas. And so they are ready for a surge, which they hope won't happen, but are expecting will happen. And they're expecting it to happen within the next couple of weeks. So from the perspective of the hospital preparedness for this, I've been very impressed by just how effective they've been, and also very open in communicating with the people on the medical and affiliated faculty to really get on top of this. And they've been very careful to make sure that it's not only the care providers on the front lines that you see, but also the people behind the scenes who make the place run, who are also being cared for. This includes people who are providing the food in the cafeterias and keeping the hospital meticulously clean. And everybody around the entire environment is pulled into this as a way to stay on top of it. A guy like me and people who in my position who are not actively on the front lines in patient care in the ICUs or in the clinical front seeing the COVID patients. Some are being pulled in to help, but for the rest of us, there's all the rest of the hospitals still to take care of. So we have moved our practice off-site. I'm at home, and those of you who've seen me on the virtual visits, I'm sitting in my study, and this has now become my little world over here, taking care of patients. I was talking about the virtual visits. What we're doing is the physicians who aren't actually in the hospital have been sent home. So basically, the entire workforce has been sent home, except for those who absolutely have to be there on site to take care of people who have the virus. There are many reasons for this. One is they need to make sure that we're all safe, because if the doctors and nurses all start having to quarantine themselves, they've got no one to take care of their patients. So it's a critical need to maintain the safety of the caregiving faculty and everybody else, because we're in this for the long run. That's number one. Number two is there's everybody else that the hospital takes care of. All you folks who are, thank heavens, unless you have what remains that way, are COVID-free. But you're still part of our community of patient-doctor interactions, and we need to be there for you. And so we've moved onto this virtual platform, which itself has its issues. We all have to learn how to navigate the virtual reality, the online platform. We have to make sure that we all have the technology that's necessary for that. Sometimes you use a telephone because not everybody has a computer that has a camera so they can see you. But in those circumstances where we have this, either your phone or your computer or laptop, we can do the virtual visit, which means we're here for you, and we can take care of questions about medications or changes in your symptoms over time, or answer the questions that you have, or assess how you're doing. So just in the last week, I've prescribed new medications, suggested new kind of therapies, altered medications, changed doses based on the interaction over the computer. And what this has taught us, which is where this can go for the long run, is that it may in fact be possible for folks for whom it's difficult to come in. It's a long distance, or getting in is a big problem because of the wheelchair involved, or someone going to take time off of work. It may be that a good upside of all of this, the real trouble, is that we'll be able to see you more regularly and without as much trouble to address all the issues we need to through this platform of the virtual visit. So telemedicine is now a reality. And I think we're learning, and I've learned, as you have learned, those who work with us so far, that this in fact does work, and it's less burdensome to come in. We still need to see you. This doesn't replace that, but it may be that we can intersperse an in-person visit with an online visit like this through the video platform, where we can see you, we can hear you speak, we can hear your concerns, we can do some of, sort of finger-to-nose testing and rapid tapping of the finger, even walking around the apartment. Much of this we can do just to assess how things are moving along, even through the platform of the video conferencing. So that's where this has gone. There are some issues, and I'll just tell you some things that have occurred to me, and I'd love to hear your own comments and feedback. There are some issues that are directly relevant. Now, one of the questions that's come up is, are people who have ataxia at higher risk of getting the complications if you were to get the virus? The big picture is this: people who are above the age of 60 tend to have a higher risk, and the risk is greater in the 70s and even higher in the 80s. So age is a major risk factor from the age of 60 upwards. But that doesn't let everybody younger off the hook. So firstly, that's number one. Number two is the things that raise your risk are heart disease, diabetes, hypertension, previous smoking, and immunological compromise. Now, immunological compromise includes people who are taking prednisone or Cellcept or rituximab or the medications for immune treatment of a disease. But also some folks may have lupus or multiple sclerosis or myasthenia or associated conditions, and all of that raises the risk because that's an immune compromised situation. But cardiac disease may occur with some of the ataxias. Some people are smokers. All of these things cause more trouble if the virus hits. And that's unrelated to the ataxia. Our concern for the ataxia patient population is that given that there's a neuromuscular problem, where there's a control of respiration and the swallowing mechanism sometimes gets affected in ataxia, these are things that place one at greater risk of airway maintenance, airway protection in this disease that primarily gets the pulmonary system, the lungs. The common symptoms and signs, as you probably have already heard, are things like cough, fever, and cough, and shortness of breath. But it can also have other manifestations. We're learning now that the fatigue is a big problem, maybe muscle weakness. Some people, occasionally, there are some neurological things, confusion, even seizures and stroke in some people, and encephalitis. That's a rare complication, but we're recognizing that may be actually part of the neurology of this virus. So those are the things that are relevant to ataxia people in terms of, number one, what the risks are if one were to get the virus, in terms of the risk of getting it, and the greater complications unrelated to ataxia. And the second is a symptom that you may have worsen even because of the ataxia. The fact that there's a neurological condition that makes things worse. That makes it all the more critical to not get the bug. And not getting the bug, you know all about, because you've heard this as we all have, but there are a couple things that I'd love to hear your own comments about this, how this may affect you. So things like staying at home and social distancing and frequently washing your hands and not touching your face when you be up unless you washed your hands. Not being near people who are coughing and making sure they cover their mouth. Or wearing a mask when you leave the house. These are all ways to make sure you don't get infected. Cleaning things when they come in the house. Something comes in the house, you bring it in, you put it in the basement, you let it stay there, you bring it up, you wash your hands. All the things that we're all reading about, these are important ways to remain infection-free. The other part of this, though, is because people are now living on their own, what concerns me is that the access to the care that was part and parcel of your everyday life becomes disrupted. How do you get to see physical therapy or speech therapy or occupational therapy? What if you have a caregiver coming in to take care of you? Can they come in and see you? Have somebody who gets a blood test for the Coumadin level they're on, they come to the house once a month. Is that a safe thing to do? What about going to the lab to get labs drawn on a regular basis? If you're on Riluzole, for example, and you get your blood drawn once a month, is that something that one can do? These are all very practical knock-on effects of staying home in social isolation. Now, we don't know how long this is going on for. If this is a matter of another month or 6 weeks, we can probably get around that. But nobody knows. They're not able to tell us this. And so that's part of the concern. So those are some of the things that we're hearing about and are needing to think about. So I'll leave it at that, just as an opener, and then be able to answer any questions to the best of my ability, given what we have. And all the other trouble, the stuff that Jeanette was referring to, getting furloughed or losing a job, and all this, the psychological trauma and the emotional trauma and the financial hit, all of these things are very real. And this is a very tough time to go through. And one of the ways to get through it is exactly what we're doing now, is to maintain community and keep the communication, keep the connection, hold strong, try and keep an even keel, and move forward. There's a lot more that I can share about in terms of what's going on in the background, but let me stop there, Dana and John, and if there are and whatever questions there are, if people want to chat about topics you'd like to raise, I'll see if I can help them.
Yeah, Jeremy, we did have a question regarding, do we know any patients with ataxia that have tested positive for corona? And if so, how are they doing?
So there's no data, as far as I know, on ataxia specifically. So when I talk about what I think may be higher potential for risk, that's on first principles. There's no published evidence I know of the ataxia patient population specifically with the COVID, except in as much as the general rules of age and the comorbidities of heart, lung disease, and hypertension. So beyond that, we actually don't know. But there are issues that are specific to the kind of problems that the ataxia community is facing that we know are additional burdens. I mean, you wouldn't think to say, I'm not able to see my physical therapist. That's a downside of being stuck at home, and yet that is a downside of being stuck at home, and that's part and parcel of your ongoing management. So that's beyond that, we actually don't know. So it's from first principles that we can say we're concerned that there may be a more troublesome outcome should somebody get infected, purely on the basis of the ataxia itself, unrelated to a heart issue or age or other perspectives.
Okay.
Oh, I just had a question, Doctor. I heard you mention that if you were on Riluzole, you should have a regular blood check. Did I hear you correctly?
It's not regular all the time, but if someone has begun Riluzole, we'll do it. We'll check out a month, and then 2 months, and maybe every 6 months or a year thereafter. So it's not a regular thing, but just to keep an eye on things over time.
Very good.
Yeah.
That's it.
Okay, great. Anybody else that has a question, other questions? Okay, Lori, we're going to Lori.
Go ahead, Laurie.
Okay, Dr. Schmahmann, I stopped taking the Riluzole because it was too expensive. I'm not seeing much of a difference. I've been off it for about a month.
So that's an interesting point, and I'll tell you where things stand with Riluzole. We know that Riluzole in the studies in Italy seemed to make a difference to the people who were taking it in 2 separate studies over the long run. The drug trial of Riluzole is a different formulation. It's a once-a-day, similar kind of mechanism because it metabolizes into Riluzole. And the idea behind the study is, does it really work? And we don't know whether it works over the long run or not. Why it's a clinical trial. And the point is, it's conceivable that you may not notice much of a difference once you're on it. But if you, I'll use my hand. So if you're in a group of people who are taking the medication, and you stay the same as you were. So if you're not noticing any difference, If there was a second group who was not taking the medication, would they tend to decline over time? So at the end of a point, at the end of a year or two, is there a difference in the two groups? The riluzole group and the non-riluzole group, are they the same or are they different? And that's what the trial is about. Do we see the difference over the long run? So it's quite understandable that you may not have seen a difference, and there could be two reasons. One is it doesn't do anything, but two, it may not produce any identifiable improvement in some people, although in others it does. But if it doesn't produce an identifiable improvement over the long run, would it keep you steady compared to somebody who wasn't on it? So that's the idea behind the clinical trial and the reason that we're using riluzole. Which gets me to a clinical trial discussion. What this has done, this whole staying at home thing, and exactly the concern that a few of you raised, that the hospital is, is not a healing place necessarily. That's where all the sick people go. Is the clinical trials have come to a screeching halt, and the Biohaven trial for troriluzole, the Biohaven trial for multiple system atrophy, and the new one that Cadence is going to be starting sometime soon are all on hold. We're not bringing in any new people into the study, and those who are already on it, we're doing virtual visits just to check in and make sure they're okay, but we're not actually doing the evaluations on the computer of the motor impairment. The reason for that is kind of clever, actually. The fellows who are running the study said, if we use the computer as our examination portal, and we get a data point, the FDA is going to say, we're going to use that data point. But the question is, what if that data point isn't as accurate as an in-person evaluation? Now you have an inaccurate data point, and the drug company's on the hook for that. So, and we agree with that, because you want to know that the drug is either working or not. You don't want to get faked out by a change of in-person exam to a computer exam. And since we don't know that, what they've decided to do is to make sure that we know that you're okay. So some of you who are on the drug studies will stay in contact with the study team, but it's mostly to make sure that you're okay. You can have bloods drawn at the local lab if necessary, or defer that if necessary. And the hope is that this will go away at some point relatively soon. We'll be able to get back on track with the studies, or at least do it in such a way that we're not going to be placing you at risk to have you come and see us or have us see you. It's everybody could be a asymptomatic carrier. I'll come back to that in a second. And the other one, the Cadence study, is on hold now. That was a new drug to try and make ataxia better. They can't initiate that because to start the study, you have to have an in-person visit with the person who's actually going to be taking the medication. So that's on hold for the moment. I think that when we get a test that will allow us to know within a matter of minutes, 5 minutes, 15 minutes, half an hour, whatever, whether you actually have the virus or you've had antibodies to the virus, that would be a total game changer. And this applies to people coming into your home as caregivers. So all the fuss about the testing, I think, is for a good reason. When we know that somebody can be proven to not have the infection, that person can come in the house and take care of you, or help out with you, or provide physical therapy, or whatever else it is. But in the absence of that, the fear of about 25% incidence of asymptomatic carriers, or people who can spread the infection 5 days before they even know they have anything wrong with them, that's the major fear. And this thing spreads like wildfire. So one person can infect a minimum of 3 people, and then that's why it goes on from there. That's why it's this exponential rise. One person doesn't infect one person can infect an average of 3 people. And as we know from the Biogen conference downtown at the Marriott Long Wharf, there are 3 people who infected 70 or 90 people. It was a ridiculous number of people who got infected. And that's the concern. And that's why they're all keeping us basically sheltering in place. But I think that the ability to test will change a lot of this.
Dr. Schmahmann, before you joined the call this afternoon, we went around and we had everyone introduce themselves, and pose a question that, was top of mind for them in terms of the COVID-19 dilemma. And so I'd like to go through a couple of those with you and let you know who asked those questions so you can address that person, and that person can ask a follow-up if they need to. So one of the questions was, and I think this has not been discussed yet, is if something happens to a child that has ataxia, how can that child be seen by you without taking the child to MGH? And I think the answer might be virtually.
It's virtual visits. We're moving to the virtual visit platform. So I think there's very little that cannot be accomplished in the long-term care of a person with an illness that cannot be done through the virtual visit. If there's an acute illness, you have to go to the hospital. If there is a concern for actually getting COVID, you have to call your primary care doc. Do not go to the hospital. You call the primary care doc, and the doc then organize based on your symptoms whether he or she thinks that it's more likely than not that you may in fact have the virus, and then arrange for the testing. So, but for regular routine care, we're moving to the virtual visit platform. And for those of you who've been in, maybe you can talk with the others about that, what your experience was, how it works for you, what the upside, the downside, all the rest of it. That's going to be the way of the future. I have patients who fly in from all over the world to see me, and that's okay for me to get to know them the first time out. But they literally fly from China, from Hawaii, from Taiwan. They come from South America. The question here is that really necessary on a 6-month basis or an annual basis, or even coming in? The folks who are down in Fall River and New Bedford, coming into Boston, as if you go, it's like you're flying from China to Boston. It's the traffic when there's normally traffic, and the parking, and it's just such a complete hassle. So the question, and then you have to get a caregiver, and you've got to get someone to take the day off of work. This allows us to ask questions that we didn't really need to ask before, and I think gives us answers that we didn't have before.
Yeah.
They make, and the knock-on effect could potentially, there are good lessons to come out of this. When they talk about the fish coming back in the canals of Venice, or the air in Boston being cleaner because the pollution's down, or the savings on the environment with all the spewing of the gasoline in the environment with the airplanes. There is a way to rethink this. And I think that we're so optimistic by nature, otherwise what's the point of getting out of bed? With something as catastrophic as this is, what are the lessons we can learn from it to better our society? And I think that one little way in our environment here is for us to have access to each other through these kind of platforms. The technology is extraordinary. I mean, look at what we're doing now. We're all in different places around the country. We're all chatting real time. And we can engage and we can interact, and be able to see each other breaks through in a sense with the face there. The visual is so important in terms of being able to see somebody and connect with them, and then get the non-verbal cues of the interaction. All of that, I think we can get with the technology, at least as good as it is at the moment.
So Jeremy,
we can do this over the long run. This will be a change in our practice, I think, long run.
So Jeremy, if someone were to have an upcoming appointment with you, how would they go about scheduling a virtual appointment? If they called the Ataxia Unit, is there someone there answering phones? Like how do they schedule this?
You don't have to. It's going to be automatic. We will send you an email saying if you want to do it by phone or by Zoom. So it's all gone. There are no one's coming to the hospital. There are no appointments.
Okay.
No one's going, like there's nobody there.
Nobody's home.
They're all out. So all of the appointments are virtual. They're either going to be like a Zoom like this, or those who don't have it will be doing it by the phone. So so I did I'm sitting at home. I've been working harder at home than I work at normally.
I agree. So have I. I can't take it.
It just saves me the commute, so I can take the dog for a walk in the morning. It's nice. We haven't changed our schedule at all. In fact, what's interesting is I don't keep anybody waiting anymore. Everybody's on time. You know when you've got your clock, you know when the appointment starts, you know when it ends, and we end on time because someone's waiting on the computer. So it's actually been very efficient. We start on time, we end on time, we know exactly how much time we have, we can take care of what we need to, and then we can set the agenda for where we need to go. We also, because we can do it in such a low kind of time-intensive thing with getting in the hospital and me having to organize my clinics around things, we could see it. We can add on the visits if we need to. It actually is a transformative approach to healthcare. It's sort of like the doctor. It's like the old patient, house call, except we're doing it through the computer.
Yeah. No, that's very true.
Yeah.
Denise, you had your hand up.
Wait, are we able to ask a follow-up?
Yep, go ahead, Randy.
So, Jeremy, if we have an appointment scheduled out for October, do we have to do anything differently? And are these appointments being billed to insurance the same way?
Yeah, so everybody's recognized that the model has changed. It literally is. When I say the world is different than it was a month ago, this is a prime example. All the fuss and the feedback that we were getting for the virtual visits like this, that's just melted away. It's like, this is what it is, deal with it. Insurance companies, deal with it. Okay, this is what this is. And it's happened. So we don't know what's going to happen in October. You may decide in October that you would like to do a virtual visit as opposed to come in. So at some point it'll become a choice thing, or it may be that I don't know if we're at this point, but you almost need to have a reason to come in as opposed to doing it on the virtual visit. Let's see where that goes. We don't know. That's all up. The word that describes it best is fluid. When we get emails from the hospital, they say, the information we're sending you is valid as of April 5th, 2020 at 5:02 p.m. Literally, because at 6 p.m. it could be different. So, because we don't know. So much has changed.
I can agree with you there, working with the hospital. As soon as I have a plan, it changes within 3 hours, and it just constantly changes. So I do understand that.
This is what I was talking about up front. The issues that our ataxia patients have, and we don't have any data at all. This is all from first knowing about the virus, knowing about ataxia, knowing about the issues that our ataxia community is experiencing. So this is not data free completely, but there's nobody we know of has gone through this, thankfully, and hopefully it'll stay that way. But here's the reality: is that this disease goes for the lungs. That's its first target, and it really does a number on the lungs, and then everything knocks on from there. And because in ataxias there is the issue of control of respiration and the strength of the body in fighting off these issues, and the trouble with the aspiration pneumonia later in the course, I think that it is quite reasonable to believe that there is a higher risk of the problems in people who have the different forms of ataxia. So yes, I would regard this as a higher risk. And in the letters I've written for people before everybody was confined to the house and they were wondering about airplane reservations and cruises and those things when they were still going on, I was very happy to write letters saying, look, this person is at high risk, you need to let them off the hook. Now, of course, that's all gone by the wayside, but the point remains the same. So yes, I think that for folks in the ataxia community, you need to be extra special careful to not get the virus. So your primary responsibility is to not get the bug. And that's where all the preventive measures come in. And so I take this really, really seriously. It's all the hand washing, so if you're at home, you haven't gone anywhere for the last couple, you're home. So where does the risk come into you? Because if you haven't had the bug so far in your home, you're not going to get it. So how could you get it? Social distancing. You're going to get it from people. So this is a zoonotic. It came from the animals, but then it got transmitted person to person. And so let me say it again because it matters. A person who doesn't have symptoms but has the virus could still pass it on. So the way that you can get this virus is either from a person who has a virus, whether or not they know it, or touching surfaces that have the virus on it, or breathing in the air of somebody who was just there a few minutes ago. Because with these, they talk about droplets and aerosol. Droplets are small collections of the particles that drop down onto a surface and stay there for a period of time. That period of time can be a day to a few days. So door handles, surfaces, the trolley cart, something in the store if you go to, those are all potentially infectious. I've heard two ways to think about this. One of them was like there's glitter everywhere. You have to avoid the glitter, or my brother said a red dust. Just imagine a red dust everywhere. You need to, that's what you're trying to stay away from. So where is that glitter or that dust? It's on surfaces outside the house. So somebody who comes into the house who may not be infected could have touched that and then bring it into the house, and that virus is on their hands and now in your home. So that's the key, is not to get this beast into your house if you're tucked away at home. How do you get exposure to the beast? Stuff coming into the house that got the virus on it. People who are coming into the house who touch surfaces. So the hygiene becomes absolutely key. Thankfully, thank heavens, soap destroys the virus. You'd think, well, why can't they just stick soap into your veins? Wouldn't that be nice? But it doesn't work like that. We need the equivalent of soap to stick into the veins. But outside of that, what the soap does is it attacks the lining of the virus and then opens it up and the thing just gets destroyed. So that's why soap. And then for the hand sanitizer, if you can get any, does a similar thing. So that's why the no hands on your face, washing your hands all the time, 20 seconds. You've seen videos. If you haven't, you have to wash the hands, you have to wash the thumbs, wash the fingers, wash the back of the hands, wash the front, make sure you're washing the hands, this part here of the hands, and doing it for 20 seconds, all the way up to the wrists, like that, all the way around for 20 seconds washing, then you wash your hands off, and then you rinse off the faucet. And you're doing that multiple times a day. What I would suggest is have a bottle of hand cream so you don't get chapped hands by the time you're done, because you literally are washing your hands a number of times throughout the day. You're becoming obsessive compulsive on purpose. It's a purposeful obsessive compulsive disorder about hand washing. And the reason is because your hands are the conveyors of the stuff into your mouth and your eyes and your nose. And that's how you get the bug. There is apparently another way as well, which also speaks to hand washing, is this also affects the GI tract. And if someone doesn't clean themselves properly after going to the bathroom, you can get the bug that way as well. So these are the critical reasons for hand washing, for using the bleach or whatever to wipe down surfaces. And people who come into the house need to not bring the bug in. So I'm emphasizing this piece on purpose because this is the key. You're already doing isolation. You're not doing social distancing of 6 feet. You're staying home. So that's the biggest thing you can do. You're doing it already. You're doing it yourself and to society. Okay, by not getting it and not passing it on. So staying home is a huge part of this. That's why there's no cars in the street, why the economy's tanking. Staying home is key. But when you're home, how could you get it? For those of you going out to the shopping or someone coming in with the shopping, you have to be absolutely scrupulous about this. Even changing clothes. So the doctors who come home, the doctors aren't coming home. The doctors in the hospital are staying in hotels or they're staying somewhere else. They're not coming home. or those who do, they're coming home and they're leaving all the clothes in the basement and sticking it or somewhere and putting them in the wash, going to have a shower and then coming back, just to make sure that this dust gets washed off of you. That's how you should think about this. Invisible, but think of it as dust.
I think, Donna, did you have a question, Donna Gazzola?
I think you're muting and she's trying to unmute. Okay.
Yeah, just wondering if regular soap works, or does it need to be antiseptic soap?
Regular soap will do it. It's the action of the soap in attacking the fat soluble aspect of the virus. The soap breaks it apart. It works. Any soap will do it. They said it should be soap that has a lather to it. I don't know if that. I don't know about the science behind that, but a soap that when you're washing your hands, you get a nice lather with the soap. That's what you're looking for.
Okay, Lauren, you had a question?
No.
Lauren, you asked a question earlier about the chime model versus other models and why the states are using different, or cities are using one over the other. I don't know if Dr. S, you have any insight into that.
I don't. I think that these are all different mathematical models people are using, but there are a couple of facts that drive this. The one is that the infection rate from one person to another is on average one person infects 3 people, and that's why you get this exponential growth. And it could be as many as 50 or 60 in these super spreaders. We know that it takes around 5 to 7 days to actually get sick. We know you can infect someone you can infect somebody else 5 days before you show symptoms. You can be spreading the virus. So that's the kind of information that they're feeding into their models, but it depends on what the movement of the population is, how dense the population is, what kind of society configuration there is in terms of a city or a town. These are all the complex issues that go into building a model, which I don't really understand. But what they do know for sure is that the numbers we have today reflect what happened 2 weeks ago.
Right.
That's an interesting fact.
Okay.
And what we know, what they say, these are the numbers for today. What's happening today is what happened 2 weeks ago in terms of spreading. So you can imagine the reason that they're worried about this wave is that in the last 2 weeks, all these people have been out there infecting 3 other people in this exponential rise. And that's the concern. That's why they're saying, oh my God, something's about to happen, because our numbers now are 2 weeks ago numbers. There's been a lot of spreading going on in that 2 weeks, so they think the numbers are going to look like that. And the problem is that the medical system can only handle so many people because there's only so many doctors and beds and ICU beds and ventilators. That's the issue.
Okay.
Good.
Other questions? Okay, Lori Sjogren, we're going to go to Lori. Oh,
One thing that we have been hearing about is some anxiety from folks if they do get it, if a family member gets it, or for any other reason they do have to go to a medical center, having that separation between family members. And what is your advice on maybe preparing for that type of situation within families?
Good question.
It is perhaps one of the most heartbreaking pieces of all of this. In addition to all the trouble that we're going through, I can't see my family. My wife is here, Jenny's here, thank God. We've got our little nuclear family, just as us. But there are people who go through this on their own, with nobody else there, and that's hard. But those who are in families, even now, before we get to the next stage, you can't see. I can't see my son who lives downtown. My brother's around the corner. I can't see him. We all have the big family, celebrations coming up with Easter and Passover. We can't do that. Grandparents can't see their grandkids. People can't see their parents in the nursing homes or the senior living centers. This is heartbreaking. And it's even more heartbreaking when someone goes in the hospital. And the doctors are now really feeling this, because one of the things that doctors, nurses, all the caregivers do is when people go through tough time, and we're God's agents, we're not God, people pass. But what we can do is try and be there and facilitate that and work with families and allow the passing to be one that is remembered as being gentle and meaningful and love-filled, and as people transition to the other side, and poof, that's all gone. Because if you can't be in the hospital, people are dying on their own. I have no words for that. None of us do. It's just horrible. So there's nothing to be said about that, except that it's just one of the most awful family, psychological, emotional downsides of all this problem, and therefore don't get the bug. I mean, the more horror stories you hear, and there are, the more it speaks to us like, stay home, number one, don't get the bug, and secondly, do what you can to prevent getting it. But not everybody can do that. So in the environment where families are separated, someone goes into the hospital, here I think you have to try and maintain contact through phone or, be in touch with the nursing staff if they can talk with you about what's happening. But I think that there's no ready fix for this. They're dealing with a medical system that is really, in some cases, breaking apart at the seams and doing its very best to stay holding itself together. But you do have very committed caregivers on the front lines who will do what they can, recognizing the pain that family members and patients are going through when they're separated from each other. You can't be there by the bedside to bring down a glass of water if he needs one, or to hold her hand if mom needs that. All the things that we do normally, naturally, as people taking care of our loved ones. So these are the harsh realities of this terrible pandemic. A very much on the ground kind of issues that we have to deal with. So I don't have an easy answer for that, the separation between family members, except that if someone's in a senior center and you can't see them, we've seen pictures of people going by and holding signs, I love you, and doing it from outside the window, and just maintain that contact. I think maintaining contact if someone's healthy but separated, using the virtual reality. If somebody's in the nursing home and doesn't have full cognitive capacity, which occurs often, obviously, finding ways to try and maintain the contact. I was reading the paper this morning that the people who have developmental disabilities, who are in these group living situations, who are now not able to see the family members who would come and see them on a daily basis. That's heartbreaking. And everybody has to find some way to maintain a sense of the personal contact, even if it's not actually in-person contact. So
I wanted to rephrase Laurie's question. I thought that was a good point, but the point that I want to ask is, say there's 3 of us in one house and none of us are affected. All of a sudden we find out one of our kids or somebody might be infected. What is the best way, or if that situation happened, is there a way to isolate the house?
Need somebody in the house, one person in the house.
Yeah.
Right.
I've read some things about that. Yes. So here, it's a separate room. Washing clothes, washing hands, trying to keep this is now a social distancing within the house.
Right.
As much as you possibly can.
Okay.
Not eating off the same plates, just they're really trying to keep things within the same household as much as you can, keep it separate. One thing that we're taking for granted here, and I think that everybody in the call is in this sense okay from this regard, but there are people who don't have their own different rooms in a house, or are living many members of a house to a small many members of family to a small house. Well, our hearts go out to them, because there the risk of cross-infection is going to be even higher. So these are all the realities of a situation like this, and to sugarcoat it is to be ignorant, but to recognize it is important. And then, you know, the thing that you all know better than I is that you go through something hard, but then you look over at the person next to you and say, oh my God, it could even be worse. And I think that's the kind of situation that we're faced with, is that as bad as it is, it could even be worse in some circumstances. But so if you have the space in the house, you want to do everything you can to maintain the social distancing, to be washing clothes, washing hands, washing surfaces, completely obsessive about that, to try and keep yourself healthy as much as you can.
Dr. Schmahmann, it's curious to me, like I'm wondering, I've heard of some cases where someone has contracted coronavirus and then they've gone through their 2-week cycle and go to donate like plasma or blood, and at that point are retested again and are still showing positive. Have you any data on that?
So I don't know the ins and outs to that, but I think people are working on, here's what I know, is that they regard you as having been negative if you tested negative twice, and I think it's over like 2 or 3 days. So you're no longer infected if your test for the infection is negative 2 tests over a period of time following the quarantine. What they're moving to now is to develop the test for the antibodies that you developed in your system to have overcome the infection and not died from it. So they're working on that as well. So the combination of the test for the infection itself and the test for the antibodies to the infection are where this is going to come down to.
Okay.
We have been getting together with my son and our daughter-in-law and my mother by gathering on a nice day in my mom's backyard and staying well apart, but having a conversation at least. Is that safe?
I think the answer now is no.
Okay.
The answer is no. You know, we were talking about this ourselves. I'd love to go and see, our son lives down there. We'd love to go see our son. We'd love to go see friends and family. And I think that the answer is that we just should not do it. The risk is just too high. Now, so here's where the uncertainty is. Okay, everybody's been in quarantine for 2 weeks. You say, well, I've been in quarantine for 2 weeks. I'm fine. They've been fine. Isn't that enough? The rationale to say, no, that's not enough would be to say, well, they're fine, but 3 days ago they went to the post office.
Right.
And they came back and they're fine. But 3 days ago, did they pick up the bug somehow 3 days ago in the post office? So you don't know that. And that's what's going on. And so it's sort of the extreme, and we're all stuck with it. But the idea behind this, and I'm not an epidemiologist. I don't know that. It's not my own work. So I'm sharing with you what I'm reading myself about the epidemiologists telling us to please be careful. Yep. And I think that sitting in the backyard and chatting seems to be okay, but it may not be, because if people are out in, for example, in Newton, as they have now in Boston, they've put bars over the nets in the basketball
Right, right.
And they've put bars on benches like, don't sit here, don't be here, because if you're not playing, basketball, but I'm not touching, well, you're pretty close proximity, but now you've touched the basketball that somebody else touched, and maybe the bug's on the basketball. Dust everywhere, invisible dust. The only way to not land up, dying in a hospital alone, God forbid, is to not get the bug.
Yeah.
It's that serious. when you see, we've had to all learn about this. I spent 2 hours today watching very detailed videos online about what's the exact physiology of what goes on. I said, why are people dying like this? What's going on? And you see the physiology of this, how this bug affects a specific cell in the lung that then causes a cascade of mischief that is unrecoverable. And then it gets the blood vessels, and it gets the heart, and then the kidneys, and the liver, and then the whole system shuts down. That's why they're dying 600, 700, 800 a day in New York. Once it runs away like a wild train, there's nothing they can do. It's just a catastrophe. There's nothing that we can do except be there for moral support. And even then, insult to injury, family can't be there. So this is just awful. For those who don't get any symptoms or side effects, God bless them, that's great. But those who are dying is a catastrophe, and those who are not dying are probably not getting away scot-free, because the damage this does to the lungs may not necessarily be completely reversible. And if there's seizures or encephalitis or other kinds of things, or heart damage to this, or kidney damage to this as it occurs, is it completely reversible? We don't know. I don't believe the data coming out of China. They're not honest. I don't believe 2,000 people died in Wuhan when they've had 10,000 die in Italy. I don't believe it, and nor should anybody else. So we know the data come from China, from Italy, and from Spain is a catastrophe. New York is a disaster, and they've done social distancing. So we don't know. There's a lot of data coming out of China, and it's been very helpful, but from the physicians. But the actual numbers, that's the government, and they're not to be trusted. So we don't know what the long-term potential consequences are. And all of that is, the reason I'm going on this tirade is it worth it to sit in the backyard for a couple hours and chat? And I think the answer is Zoom.
Zoom. I agree.
So, it's reaching that 5:30 mark. I know you probably have a lot going on, Dr. Schmahmann, so I just wanted to end with two different things where we are not showing any more questions through the chat. One is that I wanted to, we listen to all this and it can be depressing and anxiety builds. And I found that a lot of people spend way too much time on social media reading so much false data. And now in today's world, we have 24 hours news. It's on all day. I mean, we actually have live clickers that some of the stations have of how many deaths they're having. I don't see what the point of that is. I get the importance of it. And I just think that people sometimes just need to ration out the time that they spend getting news and information. I think it's very powerful. But then to also spend time with family, just watching movies and getting your mind off of it makes you also healthier. Anxiety and depression is going to be the next big problem that we're going to face in society.
I couldn't agree with you more. I think that's totally right. I would, we've pretty much stopped watching the news here. I get the updates from the hospital all the time, and I'm reading stuff so I can stay abreast because I need to know this stuff. But I listen to occasional briefings now and again. But I think that taking care of one's own emotional well-being is an important part of this. Jenny found a wonderful movie we watched last night called Yesterday. If anyone nobody's seen it, it's a wonderful movie, uplifting movie called Yesterday. It's about the Beatles. To find uplifting things to watch, to see, to talk about, and in a sense, try and make lemonade out of this lemon. At home, reconnect with family, be thankful you get to spend time with the dog. The things that, or do some reading that you wanted to do that you haven't had time to, pick up a good book. If you can get out, go for walks, watch out for people who are out there, wear a mask. You can wear a mask now, out in public, so nobody breathes on you. Just stay away from folks if you need to. Most of our ataxia folks are still able to get up and out, either in your chair or for a walk. Try and get outside, enjoy the weather as it gets nicer, doing it with only members in your own family, staying away, across the street if necessary, stay away from other people. And then try and see, if possible, some of the spirituality that comes out of the communities coming together. I think that faith communities can be very helpful. I'll just tell you from our story, and you can align this to yourselves, whatever your own faith community is. The churches and synagogues have shut down. The only people who go there are the clergy. Nobody else can go. So in our synagogue, they have a Zoom service every day, and they connect with us. We connect with them, and the rabbi gives little sermons about tying into what this could mean in terms of spirituality, and what this means in terms of humanity and community, and you will have the same things in your own communities, and if that's something that speaks to you, I would tap into that. Or the community of the ataxia people, just reaching out to family and friends and talking to people. And you realize something that's interesting is you realize who's important to you, and now you know who you're missing. So I agree with you completely, John. I think you want to try and not wallow in this, but recognize just how grave it is, and then do what people have always done, which is reach down into our human strength and spirit and find a better way through. Find the positive, and trying to hang on to that little kernel of it.
So I just wanted to leave with one other thought I had, that many people wonder, is the ataxia work coming to a slowdown because of all this spread? And I can safely say no. I know from NAS's point of view, we're already working on the future. I've already sat in multiple of Dr. Schmahmann's virtual labs where he's able to bring people all over the world at his team meetings every other week. And so the work still goes on today, even though they're not in a office that, and it's still happening. The other question that came through was, what are we doing about the NAF fundraising? And we've been in touch with different groups that are coming up, and we're planning everything on a 3 to 4 month lookout. Some of them are going to be virtual because that's the safest way to go. And again, everything is fluid, so it changes, rapidly. But for the next 3 to 4 months, I really can't see any of us getting together in any kind of a group setting, unless a miracle just appears. But those were the two things that I just wanted to leave with. And I didn't know if you wanted to leave with anything, Dr. Schmahmann. And
I agree with all of that, John, and it's lovely to see you all. Be strong. Know that we all care about you and each other. And I think that trying to keep an even keel and hanging on to stuff that before this virus was important to us in our lives is still important, and it becomes even more so as we recognize the threats that are facing. So just hang in there for the long run. We will get through this together, and we'll be stronger for it.
Yeah. Now we're going to just turn it over to Lori Sjogren for a second.
Oh, I just wanted to hopefully do something fun and take a picture or screenshot of everyone, but I didn't want folks to be caught off guard. I want everybody to do a big smile. So 1, 2, 3. Awesome. That's great. Thanks.
Thank you.
All right. And so I want to thank everybody for coming, and we look forward to doing this. We're going to look also to do some more of the podcasts with Dr. Schmahmann with like a coffee chat with different things that arise, and we'll work out those schedules. But we wanted to thank everybody for coming, and this was a fantastic time. And
Everybody, take care.
I'm glad everybody is well. Stay
Yeah.
healthy, guys, and safe. And it was great seeing everybody.
Good to see you, Lauren.
Yeah.
Okay,
See ya.
bye.
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 guys.
Bye.
Bye.
Take care.
Thank you.